My name is Dr. Svetlana Koval. I am the owner for Dr. Koval Orthodontics in Boca Raton. It's the airway-oriented practice that focuses on treating craniofacial anomalies that are associated with sleep-disordered breathing in children and adult patients. We're going to talk today about the treatment modalities for pediatric sleep apnea. And sleep apnea, as you all know, is a part of the spectrum of sleep-disordered breathing, which is, as I've mentioned, is a spectrum of disorders related to breathing during sleep. What that means is that childhood snoring is also a condition that is found to be at the beginning of that spectrum of sleep disordered breathing, not necessarily indicating of the sleep apnea or obstructive sleep apnea. And obstructive sleep apnea is just one condition that is a part of the large group of sleep disordered breathing. Sleep apnea is a sleep-related breathing disorder that is characterized by the decrease or complete halt of the airflow despite of the ongoing breathing effort. What that means is that there is still a central mechanism to promoting and triggering the breathing effort, but this breathing effort doesn't go through down the upper airway due to some kind of resistance that is created along the way. And what matters most is that the prevalence of the sleep apnea is pretty high among children of preschool age, not even talking about the adults, where the prevalence could be as high as up to 20% among the population. So today, the purpose of our conversation is to talk about the main treatment modalities for the pediatric sleep apnea. And as I've mentioned, the pediatric sleep apnea is very prevalent among the preschool children. What that means is that children of below 3, 4, 5 years old are more prone to developing this condition compared to older children, due to some specific physiologic components to their development and to the development of the pharyngeal tissues, to the development of the facial region. That is, of course, a huge component to the development of the upper airways. So the pathophysiology of the sleep disordered breathing, and in particular the obstructive sleep apnea, involves two main components. First of which is the anatomical component. So it's the anatomical predisposition, the anatomical structure that defines the decreased airway flow, either through the longer airways, either through more risk of the airway to encounter some kind of obstacles along the way, the airflow, or due to some well-developed mechanisms that create the resistance of the airway passages. If we develop more on this topic, the developing on the resistance, what can potentially cause the increased resistance of the airway passages? First, it's a huge component, it's a huge risk factor, which is the predominant risk factor in the adult population. It's obesity, it's overweight. So those who develop increased BMI indexes, or the children who actually gain their BMI at higher levels, at higher velocity compared to their peers, those children are at more risk of developing sleep apnea. And the pathophysiology plays exactly the same role as with adults. So obesity causes excessive fat accumulation at the base of the tongue, and it causes excessive weight and fat accumulation in peripharyngeal tissues. So the thickness to the airway wall around the pharynx, in the areas that are more prone, more susceptible to developing, creating that increased resistance to the airflow, that thickness to those walls, that is increased with excess fat deposition. And that also creates less flexibility in that wall, creating more pressure within the wall itself, creating more pressure that the wall creates relative to the airway, relative to the downward airway flow. Increased size to their tonsils, to their adenoids, to their lymphatic tissues that are located within the upper airway passages. The second most pathological component, the component that plays a significant role, is neurochemical regulation to the upper airways. Again, we're talking about the mechanisms that control the airway patency, the resiliency of that airway flow due to the pressures of the oxygen, partial pressure of the oxygen due to the partial pressure of the carbon dioxide and blood flow, which are measured by the brain mechanisms, by the peripheral mechanisms that regulate those pressures and that regulate the patency and the resilience of the airway wall, again, due to the mechanisms that are regulating the airway and the cardiovascular component, which are closely related. So cardiovascular chemical receptors that are located in the brainstem, that are located in peripheral areas, they respond to the concentrations of the peripheral and central oxygen saturation on oxygen concentration within the bloodstream, and they regulate also the concentration of the carbon dioxide. So these mechanisms are the predominant in controlling the resilience of the airway wall within the upper airway passages, and the controlling the dilation or the constriction to the muscles that regulate, again, the cross-section of the upper airways. So going back to the treatment modalities for the obstructive sleep apnea in children, and especially in children of the preschool age, I'm referring to the guidelines of the American Academy of Otolaryngology and Head and Neck Surgery, and in 2019 they have released the updated guidelines for treating the adenosylectomy procedures in relationship to the obstructive sleep apnea. So what that means is that clinicians should ask the caregivers if the obstructive sleep apnea is present, if they were initially diagnosed with this condition, if the child was previously diagnosed with obstructive sleep apnea, then the polysomnography or the lab sleep test or the sleep test in general has to be administered before executing the adenotonsillectomies. The recommended baseline measurements, baseline condition before executing such a procedure has to be monitored by the polysomnography, which is done before and 12 months after the condition. So again, all these studies, they refer to craniofacial anomalies, which are a huge risk factor for developing obstructive sleep apnea in preschool children and in children in general. And the adenotonsillectomies are the procedures that are very well shown in literature to be beneficial for treating the obstructive sleep apnea. The treatment that extends beyond adenotonsillectomies for the children who suffer and who were diagnosed with obstructive sleep apnea condition, even though the adenotonsillectomy is the most efficient and it was shown to be the most efficient in this age group, again, tackling the major component of obesity, the overweight, is also a huge component to treating this condition. Also, a huge component to treating the obstructive sleep apnea, especially in children, is utilizing the anti-inflammatory treatment or therapy, which involves intranasal steroids, which involves montelukast. The huge component is the orthodontic therapy, and orthodontic therapy tackles craniofacial anomalies and malocclusions that were very well documented in the literature to be associated with sleep disordered breathing, such as retruded maxillas, skeletally narrow maxillas, retrognatic mandibles, mandibles that are misaligned with the maxillas due to maxillary dysplasias or due to insufficient growth to the maxilla. Maxilla can be underdeveloped in several dimensions, including the transverse dimension, including the anterior-posterior dimension, meaning that if there is a maxillary dysplasia or hypoplasia, that would inevitably cause consequences on positioning and the size of the mandible. So the mandibular retrognathia is usually associated with some kind of a developmental disorder or hypoplasia of the maxilla. And as a result, as it was shown to be efficient for treatment of adult patients, the treatment which is aimed at repositioning mandible, which as a consequence is associated with the maxillary position and maxillary dysplasia or maxillary hypoplasia. So these treatments, they happen to tackle both components, not only the mandible. And for children obstructive sleep apnea, it's also important that we understand that the first line would always be the positive pressure, and that can be executed with the high flow nasal cannulas. And again, if the symptoms are severe, the severe sleep apnea in children, that has to be tackled with correction of the symptoms, with correction of the overall oxygen saturation and the components that were shown to be below normal values with the polysomnography testing. So for the children, as we go back a little bit to testing and to diagnosing, in children it's difficult and most of the time to perform regular testing and the regular diagnostic procedures as we do in adult patients, but those components that tend to screen and reveal the predisposition or the risk of developing obstructive sleep apnea, they have to be taken seriously. And as dentists, as orthodontists, and dental providers, we are the first line of screening these patients. So that's going to be our wrap up for this little session on talking about the methods of treatment for the obstructive sleep apnea in children.